It's my pleasure to welcome student Dr. Kain to the room. Student Dr. Kain came to me with a case report titled Subarachnoid Fat Embolism After Trauma to a Tarlov Cyst. By way of introduction, student Dr. Kain came to KCU with a Bachelor of Science in Human Biology and a Bachelor of Arts in Spanish from Michigan State University. While at Michigan State, he presented at the Undergraduate Research and Arts Forum as well as the Chemistry Forum. But since coming to KCU, he's been on the Dean's List, a member of the Gold Humanism Honor Society, Psi Sigma Alpha National Osteopathic Honor Society, and Sigma Sigma Pi Honors Fraternity. In 2018 and 19, he was the recipient of KCU's Michigan Scholarship and more recently has received the COMLEX I Excellence Scholarship and the Presidential Hall of Scholars, Dr. and Mrs. Dolores Ricci Scholarship. He's also served as Psych Chair of the KCU's Primary Care Club, and since the pandemic has volunteered for COVID-19 testing in the Detroit Health Department. And on a personal note, he's one heck of a chess player and a fairly adequate guitar player as well. So let's welcome student Dr. Kain to the room. Kevin, take it, and if everybody could mute their microphones, that'd be great. Student Dr. Kain, take it away.
Hello. Thank you, Dr. Sanger, and everyone for attending and having me here. I'm going to present a case on subarachnoid fat after a fall. Let me see if I can share my screen here. Let's see. All right. So I think that should be sharing now. So this is the case report. My name is Kevin Kain. I'm a fourth-year medical student at KCU, the Joplin campus. I got involved in this case report initially because I was on a radiology rotation and had expressed an interest in radiology. And one of the radiologists I was working with was talking to me about how he had this case and he had been meaning to write it up, but just hadn't gotten around to it. So we worked together to get this started, and we're planning on submitting it for publication within the next couple of weeks. I have an interest in neuroradiology, so this case was also relevant to that. An introduction to this case. So trauma is a very common cause of presentation to the emergency department. Whether it's a fall, blunt trauma, motor vehicle collisions, any kind of trauma, you'll see a lot of it in the emergency department. And you should also always review your own imaging studies. You don't have to be a radiologist to pick up on some things. And in some cases, even just understanding some basics can make a big difference in how care is managed. And I think we'll see that a little bit in this case. So the clinical history, an 80-year-old female presented to the emergency department after being found down at home for an unknown amount of time. EMS brought her and reported a large amount of blood present on the scene. On arrival, her Glasgow Coma scale was 14, and family reported a history of falls due to recurrent hyponatremia and dizziness. The patient's finger-stick blood glucose was 56 at presentation, and her temperature was 88 degrees Fahrenheit. So she was pretty hypoglycemic, so they gave her an ampule of D50 to help out with that, and rewarming procedures were started. I'm only going to kind of talk about some of the pertinent physical exam findings. So some significant findings were on head, ears, eyes, nose, and throat. There was a posterior scalp laceration noted. There's no hemotympanum, so no blood in the ears, or any signs of rhinorrhea. On the musculoskeletal exam, there was bruising over the bilateral lower extremities and a large and tender, painful hematoma over the sacrum just below the lumbar spine. On neuro exam, the patient was alert and oriented ×3. Her cranial nerves were grossly intact. Movement was present in all extremities, and the patient's sensation was intact. And like I said earlier, the Glasgow Coma score was 14. So this is just, if anyone's unfamiliar with how the Glasgow Coma scale works, this is how you score it. You have 3 domains. You have an I domain, a verbal domain, and a motor domain. So this patient here had 14. The maximum score is 15. She lost a point in the I domain because she only opened her eyes in response to voice. But otherwise, she was oriented, able to converse normally, and able to obey motor commands and move. The initial workup. So the patient was evaluated along with the ED providers by the trauma team in the emergency department. A slew of labs were ordered, as well as imaging studies. Some of the imaging studies we're going to talk about that were part of the initial workup include a CT head and a CT thoracic and lumbar spine. So when someone presents to the emergency department with head trauma, as this patient did with the posterior scalp laceration, it's important to know whether or not it's appropriate to order a CT head. And we can use this clinical decision-making rule called the Canadian CT head rules to determine whether it's appropriate to order or not. So here's some of the criteria for whether you should get one. I try to bold the ones that were more relevant for our patient. So you would get a CT head if they had a decreased Glasgow Coma scale. Within 2 hours of the incident, this patient was found down after an unknown amount of time. So it's kind of iffy whether or not she would meet criteria by this. A suspected open skull fracture, which didn't really look like this patient had on physical exam. Signs of a base of skull fracture. So that's why I mentioned the hemotympanum and the lack of rhinorrhea. Those would be physical exam findings that would make you a little more concerned for that. Vomiting more than twice, age greater than 65 years old. So our patient met that. She's 80. Amnesia post-event greater than 30 minutes or a dangerous mechanism of injury. This is things like falls from significant heights, car accidents greater than 35 miles an hour, things like that. So our patient met it certainly by the age criteria and possibly a couple of these other ones. So this is a couple slices, axial view of the initial CT head. I'll give you just a few seconds here to see if you can find the abnormalities.
Kevin, this is Dr. Johnston. Before you go further, would you mind reviewing the patient's vital signs? I didn't catch that.
Got you. Okay, certainly. So the patient's vital signs, I don't have the exact numbers in the presentation. However, I know they were all stable. So afebrile, blood pressure was within normal limits. The pulse, not tachycardic, not bradycardic, anything like that.
Okay. So the other question was pertinent past medical history. Did you provide?
She had a past history of falls as well as hyponatremia, but that was all that I found pertinent to this case.
Okay, and no previous usage of medicines?
Not that I found. The history was somewhat limited. The family ended up providing some of the history later on.
So at the time the lady presented, you didn't have access, or you retrospectively don't know what medicine she was on. Is that fair?
Yes.
Thank you very much.
Yep. So to take a look at the CT head, something that I've been told is a good rule of thumb to consider is you want to look for symmetry. So if you see something asymmetrical, that should maybe throw up some red flags. So I'm going to put
Dr. Kain?
Yes.
Dr. Johnson, you have a question?
Jeff, I had already I said I already asked my question. I forgot to lower the hands. Thank you.
Mike Johnson.
Did you hear me?
Yes.
Okay, I'm good.
Okay, sounds good. Thank you. So these arrows are pointing to the significant findings on this head CT. Using kind of that rule of the symmetry on this image here on the right, you can see that there's these dark spots that aren't present on both sides. So that would be something to be a little concerned about if you saw this. And then just to give you a reference, our patients on the left and then some reference images are here on the right. I had a hard time finding the exact same slice for a reference image of the CT head, but I think these images still show something important here. For our patient, you see these black spots here. However, on the reference image, you can see that it's a dark gray, but not black. So that's how you can tell this is the abnormality. So these are referred to as hypodense lesions because they're darker than the brain parenchyma. And what that means, these hypodense lesions most likely represent air or fat. So if it represents air, it's called pneumocephalus within the brain. And it's important to determine the location, whether it's extraaxial or intraaxial. Pneumocephalus, when present, is commonly caused by trauma. And this patient had trauma. It's a neurosurgical emergency. It can compress the brain parenchyma and lead to herniation. And if that's the case, it's called a tension pneumocephalus. You can see this finding with basilar skull fractures too. So kind of paying attention to your physical exam is important. If you have some of those signs that's concerning for that, this is maybe going to be a little more worrisome. You're going to be thinking more towards this. In terms of fat, if you see intracerebral fat, you still need to determine the location. Trauma can be a common cause of intracerebral fat in certain locations. A common presentation of this is with long bone fractures. You can end up getting some air through the vasculature that ends up in the brain. We'll talk about that later. So the question becomes, how do you differentiate between the air and the fat here? And you can do that with a Hounsfield unit analysis. So air density is around -1,000 Hounsfield units, and fat density is around -100. So just to kind of talk about the Hounsfield units for a minute here, it's a dimensionless unit that is used in CT images, and you can use it to help differentiate different tissue types. Water is kind of just set at 0, and then you can take a look at the scale, and when we look at CT scans, we typically think bones are bright white, which matches here where it has bone at around 1,000, and we can see air all the way at the other end of the spectrum at -1,000. And this is something that imaging software has built into it, the ability to do this. All your PAC systems, you can open up a tool to do a Hounsfield unit analysis and just highlight like a certain region or a spot that you're interested in, and it'll give you this information. So if you need to make a quick determination, is this air or is this fat? Is this something that maybe looks like a potentially tension pneumocephalus? You could do this yourself and kind of get neurosurgery on board. So the radiologists, what their reading of this was, they noted multiple hypodense lesions in the subarachnoid space, particularly the basilar cistern. As we talked about, these lesions most likely represent fat or air. They did the Hounsfield unit analysis, which revealed these lesions to be consistent with fat. And then there was no evidence of basilar skull fracture, other acute intracranial pathology. So that lines up with the exam that lacked the signs of the basilar skull fracture. So it's determined that these findings were fat. So fat in the subarachnoid space. This is a rare finding, and when it's present, it's most commonly associated with a rupture of a dermoid or epidermoid cyst, or from post-surgical changes associated with the removal of these cysts. These cysts are caused when embryonic ectoderm is trapped within the closing neural tube during development. So it's a congenital problem. Complications of subarachnoid fat include aseptic meningitis, hydrocephalus, and ischemia. It's pretty rare, so long-term outcomes haven't been well studied, and there's not a definitive management protocol for when you see this. However, a small number of case reports that have looked at similar patients found that they had no significant complications and required no neurosurgical treatment. So a more common way you may see fat within the brain is through something called a fat embolism syndrome. And this is what's more commonly tested in medical school. I remember seeing this in class. And it's associated with long bone fractures. So when you fracture a bone, the fat can pass into the vasculature. And then if there's a shunt from the right to left heart, it can get up into the vasculature in the head. You can have no CT findings, or kind of the classic appearance of this is this star field appearance, which is caused by scattered areas of edema and hemorrhage. So if you look at this image, you can see there's lots of very small little white dots, and that's the finding kind of classically associated with this. Other symptoms you may see in this fat embolism syndrome include altered mental status, a petechial rash, and a shortness of breath. So this isn't what our patient had, but I thought it would be interesting to mention just kind of something similar that's more common that you may end up seeing. So kind of back to our patient here, an MRI of the brain was ordered to better characterize these lesions. So this image here is a T1 weighted MRI, and it shows this hyperattenuating lesion that the arrow is pointing at. Where the fat was on the CT, we can now see it on this T1 weighted MRI. And on T1 weighted images, fat's hyperattenuating. So this is consistent that with the Hounsfield unit analysis that these lesions are indeed fat. So again, I had a hard time finding an exact same axial slice, but just to show you here on our patient, you can see this hyperattenuating lesion, and there's no such thing in the reference image. So if you see something really bright like that on a T1 scan, you can think potentially fat. So continuing with the case, this showed that there was subarachnoid fat. There were no signs of the most common causes, the dermoid or the epidermoid cysts. So the question becomes, where did this come from? The differential of the fat, other than these cysts we've already talked about, includes fat-containing spinal tumors, or certain types of contrast can remain and go up into the subdural space from certain types of myelography. So certain imaging studies can have this finding with them, but there was no history of anything like that in this patient. So then the question became, where did this come from? And going back to the initial workup, a CT thoracic and lumbar spine had been ordered due to the patient's pain over the sacral region and the physical exam findings, that painful hematoma. So these are, in the left side is the axial view of the sacrum, and then we have a sagittal view on the right. So I'll give you just a couple seconds here again to see if you can find any abnormalities here. All right, so I'm going to click to the next slide and reveal them. So put the arrows in. There is a significant finding here in the sacrum. On this axial view on the left, we can see the arrows pointing to the sacrum. It looks like there's potentially a small fracture here, and then just anterior to the bony process there, you can see there's this cyst there. And then on the sagittal view, you can see it as well. It doesn't look like it's just bone going all the way through. There's kind of something cut out in a way into the sacrum. So just to give you some reference on an axial view, the left is again the patient we're discussing. You can see that there's bone, and then in the reference image, anterior to that, there's not this big kind of space that we see here on the left. So that's how you know that this is an abnormality. And then on the sagittal view, it's maybe a little more clear here. in the reference image, you can see the bone is pretty consistent going all the way from the top of the sacrum down to the bottom. Where in our image here, you can see about halfway through, there's an abnormality there that the arrow is pointing to. So they read this as a Tarlov cyst within the sacrum and a fracture of the sacrum likely extending into the Tarlov cyst. That's what they found. And then they got an MRI to better characterize it. The left side is T1 weighted, right side is T2 weighted. So you can see again that this finding is present on the MRI and the T1, and then in the T2, the image is a little more interesting, I think, is you can see within this region we're interested in, that cyst there, there's a fluid level, and this was read as a fluid level likely representing hemorrhage, so that would be consistent if there was a fracture had entered the cyst. In addition to these axial views, they got a coronal view, and here you can see that there's kind of, at the top of the sacrum, it looks like bone, and it's one shade of gray. However, once you get a little lower down, you see all this hyperattenuation. This was read as bony edema, likely representing a fracture, which would be consistent with the findings in the other imaging studies. Just to give you a reference of what a typical coronal view of a sacrum might look like, on our patient on the left, you can see that there's all this hyperintensity that's not present here on the right in the reference image. So that's what should kind of make you a little more concerned when you see this. So what is a Tarlov cyst, this thing that they found? They're also known as perineural cysts, and they're CSF-filled sacs on the nerve root sheath, found most commonly in the sacrum. They communicate with the subarachnoid space, and they're somewhat common, actually. They're estimated to be in about 5% of the population, but among people who have them, they're only symptomatic in 1% of cases. So when they're symptomatic, symptoms include radicular pain, paresthesias, bowel or bladder incontinence, and our patient didn't really have any of that, just pain, it seems, from the fall. There's little consensus on the best management when you have a symptomatic Tarlov cyst. There's a number of treatments you can use, surgical or transcutaneous. A 2018 review that I read found that there's better long-term resolution of symptoms in patients who are surgically managed, although they more often had temporary complications. So the patient for this case, she was admitted for hyponatremia that had been found on labs, which is consistent with the history family provided of this patient having recurrent hyponatremia, dizziness, and then falling. During the stay, neurosurgery and ortho and the ortho spine surgery teams were consulted. They decided there was no urgent intervention needed at this time. The patient remained alert during the stay and didn't suffer any significant complications from the subarachnoid fat. So you would be thinking the aseptic meningitis that was mentioned, ischemia, the patient remained alert, had no significant changes in neurosymptoms. So just some conclusions for this case. Because Tarlov cysts communicate with the subarachnoid space, it's likely that the sacral fracture that extended into the cyst was the likely source of the subarachnoid fat. Just like how a long bone can fracture and the fat enters the vasculature, here the sacrum fractured and the small amount of fat entered the Tarlov cyst, and then through that communication ended up making it up into the brain. This is especially likely given the absence of any of the more common causes of subarachnoid fat, those cysts or other spinal fat-containing tumors. There's no definitive consensus on the management. Case reports suggest that they may do well with no invasive intervention, as this patient did. And Tarlov cysts are a common incidental finding, but are rarely symptomatic. These are my sources. And if there's any students listening, I just got involved in this case because I was, interested in radiology and had expressed that to the radiologist I was working with. So if you show up and are eager to get more involved, it's definitely possible to get Embolism. And we are trying to do some for publication. So I see that there's a couple raised hands. So I guess I'll take some questions.
Ken Stewart, go ahead.
Yeah, so Kevin, I just want to say what an awesome presentation. You really make us proud as the clinical faculty. You have really put together an excellent presentation with very uncommon abnormalities. So I really want to applaud you on that. You're obviously going to go very far, Kevin. You know, you just nailed it. I kind of stumbled across it. Jeff had sent me the invite, and I thought, well, I'm sitting here at my computer. I'm just going to see what's going on with the research group. And I'm really glad that I tuned in because, you know, I learned a lot on that. You really did a great job explaining, you know, this is the abnormality, this is what you would expect to find, and comparing it to a normal finding to be able to make that comparison. Really well done, Kevin.
Thank you. Then Dr. Johnson.
I would echo what Dr. Stewart had just mentioned, Kevin. Again, very impressed with the way you've organized this and the clarity of your presentation. I've got a couple questions, just not clear under the circumstances, because if you look, granted that the neurological examination was fairly benign, and yet there is some implications of a level of hyponatremia that was low enough to help justify admitting this lady.
Right.
So can you tell me what the sodium was?
Let me see if I can find that real quick. So the sodium was 127.
Okay. Well, the rule of thumb, as you well know, is never treat a number. However, if the number fit the clinical manifestations, then whether or not that contributed to her dizziness and her fall in a setting of normal vital signs, this is kind of something that we stumbled on. And I say that based upon, not figuratively here, but she did fall. And the mechanism for the fall is perhaps related to low sodium. And that's a hard sell. But she's 80 years old. Now, the other issue that I ask you to think about is the underlying etiology of why she developed hyponatremia to begin with. Hence, that's why I asked you about her medicines and her fluid intake, whether she drank a lot and is this delusional hyponatremia versus did she truly have sodium loss. Well, it doesn't sound like she had any sodium loss based upon normal vital signs.
Right.
The fact that she had a fracture of her sacrum, and then all of those then led to the finding that you found a Tarlov Cyst. And I think there is the $64 question, what do you do with it? So I pose that question to you now. Now that it's there, I don't think it's got anything to do with her sodium. So what do you do with the cyst that's there now?
It seems like you could offer intervention, you know, if it was bothering the patient. In this case, I'm not sure what the outpatient follow-up was, but I know that she did not have surgery for it, nothing acute while she was in the hospital. I think they wanted to just kind of check that none of these complications developed with this finding.
Okay, that's fair enough. And I thank you very much. I enjoyed your presentation. I thought it was a good, interesting case. It's not something that I've seen a few, but I don't think not quite as impressive as this one. I've seen some folks that have had some low back pain or certain things like that. I've never had a manifestation of a fat embolus from one of these. But thank you.
Thank you. I see there's a couple other hands. I'm not sure who to go with. I can't remember who raised their hand first. Maybe Dr. Wolf?
Are you
ahead, Dr. Wolf?
muted, Dennis?
No, he's not muted that I can see.
Can you hear me now?
Yes.
Yes.
All right. I was curious where this fat embolism actually was. I mean, I'm assuming it was not, there was no way for it to get intraventricularly because of so you weren't necessarily worried about having the aqueduct of Sylvius or anything, if that's, am I remembering my terms correctly? I mean, you weren't worried about that being plugged. So what you were actually seeing was fat emboli that had risen up and were somehow collected around the base of the brain in the supporting cerebral spinal fluid, or where was that? Were they actually trapped in there, or were they mobile? And was there any concern that they were going to cause any damage before they would actually be digested away, or whatever happens to them?
Right. So they were found in the basilar cisterns. So I think they had entered the subarachnoid space. The concern was that you could get an aseptic meningitis from this, or potentially that they could block the normal flow of CSF, and you could end up with a hydrocephalus. In the case of the patient, they didn't develop any signs or symptoms consistent with that during their stay.
Okay, thank you.
Thank you. And then I think there's a couple more.
Yeah, go ahead. I'm sorry, Dr. Sarsour, go ahead.
Yeah, my question is close to Dr. Wolf. So in your presentation, by the way, fantastic presentation. Thank you very much. So your presentation said that they did not find any, for that fat embolism, have no real adverse effects, right? During your presentation, how they measured that, or how they assess that?
During admission, I believe these were the only imaging studies that I had received. I didn't actually see this particular patient. This was something, as I mentioned in the beginning, the radiologist I'd worked with had been saving this case because they found it interesting. So I wasn't involved directly in this patient's care, but it's my understanding that they got repeated neuro examinations, which showed no change. But these were the only images I received.
Also, for the sake of, if we want to research that more and make sure that this actually fat, won't be a PET imaging, functional PET imaging for that fat will be, beneficial there if we want to research it more.
Mm-hmm.
I think that if the fracture led to that, damage and release of these fats, and then they travel up there, and it will be very interesting to do a PET imaging study on how that fat really actually formed and how it clears over time.
Certainly. Thank you.
Dr. Stewart, go ahead.
Yeah, so I just want to make a comment, and that is that, I mean, this woman's 85 years old, and she's been living with this condition for probably all her life. And so, just because we can do something doesn't mean that we have to do something. And so my argument would be, if this woman has no neurological sequelae as a result of her injury, and she's 85 years old, going around and messing around with this and trying to fix something that's not broken can actually create more of a problem. And so, I think it's a fascinating case from the standpoint of, just being able to kind of be the detective and trace it back to its origin and its manifestation. That's the exciting thing that we all get excited about in medicine, when you have something that presents kind of atypically, and then you get to be the detective to figure it out. And so, and I love the fact that Dr. Johnson's on the phone call, because as the typical internist, he's going to turn over every single rock and figure out, you know, what in the world led to the entire presentation, which is why he's an internist. I, on the other hand, being an ER physician, like the idea that we were able to, stabilize her, or get her sent to the right people so they could look into why she was hyponatremic and what may have led to this whole event. And so it just goes to show how different elements of the team come together to bring about resolution of a very, very interesting case.
Dr. Stewart, I agree with you 100%. Perhaps, and Kevin, you probably know in hindsight, probably the best thing to do is just leave her alone, and just see if the numbers hopefully will equivocate and get back to near normal. But again, if she's neurologically, she's asymptomatic with that number, I wouldn't get too excited about it. So bottom line, I think everybody compliments you on your presentation, your depth of knowledge of neuroradiology. I'm impressed. I was lost until you told me where the lesion was, and but I appreciate you doing that. So thank you again very much. And I agree with Dr. Stewart. You're going to go a long way. Thank you.
Thank you.
Anybody else? Now, Student Dr. Kain, let me add my congratulations to you. Dovetailing with what everybody said, from the moment I saw this presentation, I knew it would be really, really good. So good choices you've made thus far. You're likely, in all likelihood, going to be an amazing clinician. So thank you for your acumen, professionalism, and thank you for this presentation.